Dear student, welcome you all to today's lecture. I, Dr. Mirza Sharifuzzaman, Assistant Professor, Department of Endocrinology, Dhaka Medical College, is going to deliver today's lecture on Hirsutism. Again, this lecture is for the undergraduate medical students, and if some postgraduate student or student who were appearing in the Part 2 exam, if they are interested, they can contact me. I will deliver additional lecture on these topics with recent advance in detail in management and evaluation. Again, this is not an important topic for the undergraduate student because it's a rare thing that you have to face in the exam, but you have to know some basics, what it is and why to treat and how to treat, who should treat it. And again, you may face few short question in the exam from these topics. But if you follow this lecture, I think it's sufficient to prepare you sufficient enough to appear in the exam, to write a short note. If you just follow this, you need not to read anymore. First of all, introduction. As we know, it's a quite common condition. It affects 5 to 10% of the women across the globe. It means 1 in 10 women are affected by this condition, and usually benign. It has no serious consequences or serious underlying cause, but sometimes it may have some underlying serious causes. But more importantly, it has some important psychosocial impact because body hair, excess body hair outside the cultural norm is not acceptable. It causes very much distressing and depression to the patient. And this is why we should distinguish between normal variants and from Hirsutism. And we will later learn some other related terms, that is hypertrichosis, that also implies excess hair growth, but there is some difference we'll discuss in later on. And whatever may be the type, whatever may be the cause, main culprit is the androgen, who is either in excess concentration, stimulates the hair follicle to growth, or sometimes in normal concentration, there is increased sensitivity to the hormone receptor that causes excess hair growth. Before going to pathology, we have to know the normal physiology. This is normal pattern of hair distribution. You see here in female, the common normally hair develops at around the genitalia, this over the pubis, and it may extend in and axilla, and it may extend in forearm or legs, but it usually never appear on the thigh or arms, abdomen, chest, or back. But on the contrary, in the male, you see here, the genital hair extends up to the thigh, and it also involves thigh. It involves lower abdomen, chest, in the chin, lips. So almost all body parts are affected by hair growth in male. So you see here, this the lower parts of the scalp, eyebrow, lashes, forearm, that appears in both sexes from early childhood or in infancy. These are the normal non-sexual hair growth, and it has no androgen dependency. That is, it's caused by growth hormone from the pituitary gland. Some sexual hair appears in both sex. These are temporal, this temporal area, and vertical parts of the scalp, axilla, lower pubic hair. These are the sexual hair, but appears in both sexes, and this is due to androgen in low concentration from the adrenals and ovaries in female. And some additional hair it develops in male, such as hair, nostrils, chin, sternum, pubic area, back. These are due to high androgen concentration. Actually, if this area is affected in female, this is called hirsutism. We have to identify different type of hair before going into a definition, before understanding the hirsutism. We see here thin, unpigmented hair that appears in fetus is known as lanugo hair. It usually replaces before birth by villus hair, but it may appear in fetus if the fetus is premature. If the child is premature, he may born with lanugo hair. But before birth, usually lanugo hair is replaced by villus hair, which is short, fine, unpigmented, that is appears before birth up to puberty, that distributed all over the body, which finally differentiates to terminal hair. This is long, coarse, and pigmented hair that is arise from villus hair. And when this terminal hair growth in male sexual sites in female, this is known as hirsutism. That means if terminal hair, not lanugo hair, not villus hair, develops in male sexual area, that is upper lip, chin, face, abdomen, thigh, upper arm. If this area is affected in female, this is called hirsutism. You have to differentiate this from hypertrichosis, where this is also villus or terminal hair that grows any part of the body. It's not androgen sensitive area, as I mentioned earlier. So when in female there is excessive growth of terminal hair in androgen dependent area, this is called hirsutism. So in definition, we have three components in female. Number 2, terminal hair. Number 3, in androgen dependent area. Before going into pathophysiology, we have to know the physiology, how hair differentiate from villus to terminal hair. You see here at birth, there is villus hair with sebaceous unit. When androgen acts on this, there is hypertrophy and hyperplasia of the sebaceous gland, and this unit is together known as pilosebaceous unit, and hair differentiate into terminal hair. And this hair growth cycle have 3 phases. First of all, anagen, when there is active proliferation at the hair follicle and hair grows continuously. When this papilla, this is when this follicle unites together, it cuts off blood supply, and thus there is stoppage of replication. So hair does not grow at this stage. This is called catagen, and subsequently this club-shaped hair remains for some reason. This is the resting phase of the hair that ultimately falls off at various period of time. In different part of the body, this turnover time is different. But however, we should know that around 6 months to 1 year, our old hair is replaced by new one. You see here the underlying mechanism of hair growth. As I mentioned earlier, this androgen is the main culprit of developing hair growth. And we know androgen have 2 sources. One is from adrenal cortex and another from ovary in women. From ovary, we have testosterone, and that converts into its further active form dihydrotestosterone by 5-alpha reductase enzyme. And these 2 act together on the hair follicle to cause growth. Again, from adrenal cortex, we have very high concentration of DHEAS, that is dihydroepiandrosterone sulfate, that converted in the peripheral tissue to testosterone and dihydrotestosterone that acts on the hair follicle. This androgen in circulation bound to SHBG, sex hormone binding globulin. So when there is high concentration sex hormone binding globulin, there is very small amount of free androgen that will causes hair follicle to growth. So we have two factors to for androgen to act effectively is number one, increase androgen, and number two, decrease SHBG. When androgen remains same, but SHBG is reduced, free androgen will be increased, and that will cause hair growth. Now, how it forms? As I mentioned earlier, adrenal cortex is dependent on ACDase. When pituitary secretes ACDase, that causes zona reticularis to produce androgen that will ultimately form to active, more potent androgen. This is testosterone, which is further aromatized, further converted to active form dihydrotestosterone. That will cause pilosebaceous unit to hypertrophy and hair growth. On the other hand, the ovarian cell is dependent on ALAs from pituitary gland, which causes secretion of the testosterone in response to ALAs, and further it is converted to DHT, as I mentioned earlier. And second thing, the SHBG, the binding protein for the androgen secreted from the liver. Okay, when some factor stimulates this secretion and some inhibits its secretion, whatever, maybe it's, I'm not going in details for undergraduate students. But if you understand just this picture, this is sufficient to understand the pathophysiology, symptoms, and investigation as well as treatment. Just remember this picture. As I mentioned earlier, androgen is mostly bound to the sex hormone binding globulin, few with albumin, only 1% remain free. This free form is active that causes different action, including hair growth. But when in women with hirsutism, they have more free androgen in the circulation, so there will be increased hair growth. So how androgen causes hair growth and why it causes hair growth? As I mentioned earlier, what are the pathophysiology responsible is number one is increasing level of testosterone or other androgen. Number two, decrease SHBG. Number three, increase activity of 5-alpha reductase, which will convert the androgen testosterone to DHT, which is the most active form, and increase responsiveness of the hair follicle receptor to testosterone. So these are the mechanism that is responsible for hair growth, and during treatment we will break this area, that is will decrease secretion of testosterone, will try to increase the SHBG, will decrease tissue responsiveness, will block the tissue to for androgen action, and we can block the action of activity of 5-alpha reductase. We'll see later on. So as I mentioned earlier, this is a quite benign condition, and in most cases there is no underlying pathology. It was quite common in women, though there is some geographical variation. But why we should detect the underlying cause, or why should we consider this so seriously? Because it causes a cosmetic problem, especially in younger women. It's very much distressing. Number two, though it's a quite benign condition, but it may have some underlying serious pathology. So we should search for serious pathology. There may be some malignancy even. So we should search it seriously. So what are the causes? As we know from our previous discussion, androgen comes from ovary, adrenal cortex. So most causes resides in these two groups, but in most cases there is no causes. There is increased tissue responsiveness to androgen. So we have no cause actually, no androgen normal, binding globulin normal, but patient have increased hair growth. This is called constitutional or idiopathic. That is, have no causes. But you have to remember, keep in mind, this run in family. So you should take the family history, whether his sister or mother have similar problem. And as it has no underlying causes, so other than hirsutism, patient will have no abnormality. There is no menstrual abnormality or no other symptoms. Number two, ovarian cause is the commonest cause, and among them, polycystic ovary is the most common. That causes increased ovarian secretion. I will discuss polycystic ovarian syndrome in a separate class. And patient may have pregnancy luteoma, or patient may have androgen secreting tumor in ovary. In adrenal, the commonest cause is congenital adrenal hyperplasia, though its incidence is quite low, but among the adrenal cause, it is the commonest. Certain patient with Cushing syndrome may co-secrete androgen along with cortisol. So this patient may have hirsutism. And again, androgen secreting tumor in adrenal may cause very high concentration of androgen that will cause hirsutism rapidly grow with virilism. Well, as both signal to adrenal cortex and ovary comes from pituitary, so disease of the pituitary itself can cause hirsutism, like prolactinoma or growth hormone secreting tumor can causes hirsutism. But before dealing into any causes, we have to look into the iatrogenic causes, because we can induce hirsutism by giving some drugs like anabolic steroids. Metoclopramide is an anti-emetic drug used commonly. Methyl dopa commonly used antihypertensive agents used in female during pregnancy period especially. Phenothiazine group of drugs can causes, and progestin quite common used in OCP. So patients who are receiving oral contraceptives may have hirsutism, reserpine and testosterone. These are the drugs that can cause iatrogenic hirsutism. So we should take history. Again, some drug causes development of hair in the sex-dependent area. This is androgen-dependent area. This is hirsutism. And some drug can causes generalized excess hair development. This is hypertrichosis. We should differentiate between these two. Again, obesity itself can cause hirsutism by different mechanisms. We are not going in detail. Then how the patient of hirsutism will present? As we know, patient have excess hair growth. Patient may come with just excess hair growth for cosmetic purpose, but patient may have other evidence of androgen excess, that is excess proliferation of the pilosebaceous unit may lead to acne. And patient may have ovulatory disorder. So if patient have ovulatory disorder, patient will have irregular menstruation, commonly oligomenorrhea. And if androgen comes in excessive amount, either from virilizing CAAs or from androgen secreting tumor, patient will have sign of virilization like clitoromegaly, muscle mass increase, development of muscle mass, frontal baldness, deepening of the space, breast atrophy. These are the features that are evidence of virilism. I will discuss it later on. Then, how will you evaluate a patient with hirsutism? First of all, when and where is the hair? When is important, because if it's developed childhood, we should look into the congenital cause, like congenital adrenal hyperplasia. But if it's developed in and around puberty, it may be a late onset CAS or commonly polycystic ovarian syndrome. And weight and menstrual history is also important. As I mentioned earlier, weight itself can cause hirsutism. So patient's weight should be evaluated. Menstrual history is important because in ovary disorder like polycystic ovarian syndrome, patient will have anovulation and have menstrual abnormality. We should take family history because certain it run in family. Even polycystic ovarian syndrome run in family, and idiopathic hirsutism also have runs in family. We should take drug history because, as I mentioned earlier, certain drug causes hirsutism. We should look after whether there is acne, which is also another sign of androgen excess, and we should look into the signs of virilization. That means temporal hair loss, voice change, clitoral enlargement, breast atrophy, increased muscle mass. Because if there is sign of virilization, that always defines underlying serious pathology. This has been discussed, how menstrual history. Then we have to assess the severity of the hirsutism by modified Ferriman-Gallwey score system. Is a modified score. You may not need to learn the detail, but you have to know that there is some scoring system in 9 different parts of the body, and scoring from each side from 1 to 4. 1 is the least amount of hair, and 4 is the maximum amount of hair, like a male, normal adult male. So if you add together, it will let you know the severity of the hirsutism. Usually, if the hirsutism is more than 15, it's called significant hirsutism that needs to evaluate. If it's less than 15, it's usually benign and have no underlying cause, either it's familial or in certain instances there may be some benign pathology like PCO or late onset CAS, non-classic CAS. But if it is more than 15, usually there may be some underlying pathology. You see here hair distribution in chest, around nipple, lower abdomen, which usually does not appear in female. You see here in chin and sideburn. We should, after assessing the severity of the hirsutism, we should examine the patient in details to identify whether there is any underlying cause. Like we should examine the thyroid to see, identify any thyroid disease. We should look into the evidence of Cushing syndrome. We should look into the sign of insulin resistance like acanthosis nigricans. We should look for sign of virilization like clitoromegaly, frontal baldness, etc. You see here the sign of virilization. There is temporal baldness. Patient's voice will changes. Patient may have acne. Breast will be atrophied. Muscle mass will be more. Muscle will be hypertrophied. And normal female body contour like white pelvis will be lost, and there will be clitoral enlargement. These are the sign of virilism, and sign of virilism always signifies underlying serious pathology. We should examine breast for galactorrhea. As I mentioned earlier, hyperprolactinemia itself can cause hirsutism, and we should look into whether they have breast atrophy, because this is a sign of virilization. And we should examine her pelvis to detect a pelvic ovarian mass, because androgen secreting tumor may arise from ovary, which in terms lead to hirsutism. After clinical evaluation, we should go into investigation, and who to investigate. Number one, before that, we have to know when we should suspect malignancy or tumor. If it develops very rapidly, symptoms are very sudden, very recent, if there is menstrual abnormality, if there is sign of virilization, if it occurs in early childhood, this patient should be investigated vigorously. Otherwise, mild hirsutism by itself need not to do an investigation. So what are the investigation we should do? If you remember this, my previous figure of pathophysiology, we will that will define what investigation to be done. Just look into this picture. This pathology, main culprit is testosterone and DHT. We can measure testosterone. DHT usually not measured. It's not available here. We can measure SHBG. We can measure androgen, adrenal androgen, DACS, dihydroepiandrosterone and androstenedione. And when adrenal hyperplasia occurs, there will be increased intermediary product of androgen steroid secretion, that is 17-hydroxyprogesterone, which increases in very high concentration in CAs. So we'll do 17-hydroxyprogesterone, and we should determine the pathology, whether it's adrenal or in ovary. We can do an imaging, either ultrasonography or in certain instances we can do CT. So in summary, we'll do testosterone, we'll do DACAS and DHEA, we can do SHBG, and we'll do an imaging. This is the most important investigation, and this usually defines the pathology. However, few other investigation can be done. See here, FSH-LH was the ratio is usually altered in ovarian dysfunction like PCO, and in certain instances when other pathology is suspected, it's not done routinely. When we suspect Cushing syndrome, we'll do a screening for Cushing syndrome, that is urinary free cortisol or overnight examination suppression test. If we suspect acromegaly, we'll do IGF-1. This is not done routinely, but when there is high degree of suspicion, we'll do other investigation. Now, treatment. Before going into pharmacological or other management, as it is distressing for the patient, we have to assure this as a normal condition, it's quite common condition, it's quietly 1 in 10 women are affected by this condition. So don't be depressed, it's quite common, and we have lots of remedy for you to remove this hair. So we have to assure the patient. Number 2, as the androgen is the culprit, we have to remove the source of androgen. Number 3, we should prevent the androgen to act on hair follicle. And number 4, we can remove the hair directly. For pharmacological approach, as I mentioned earlier, you see here straight cat condition. We can prevent androgen to act by giving anti-androgen. We can prevent testosterone to be activated by 5-alpha reductase inhibitor. We can give metformin or oral contraceptives that will increase SHBG. We can give OCP to suppress LH that will in turn prevents testosterone secretion. Or we can give dexamethasone to suppress adrenal androgen secretion. So when the pathology is ovary, we need to suppress ovarian androgen secretion by combined oral contraceptive pill. If sources androgen from adrenal glands, we can use corticosteroid to suppress ACTs, which in turn will suppress the androgen secretion from the adrenal cortex. We can block the androgen receptor by spironolactone, ciproterone, or flutamide. Flutamide is a hepatotoxic drug, not used nowadays. We can prevent testosterone to become active by giving 5-alpha reductase inhibitor, finasteride. We can use insulin sensitizer, metformin, that will increase the SHBG, that in terms will decrease the active androgen. We can use topical agents that will also inhibit androgen to act on hair follicle. Epronethine local cream can be used on a hair follicle to prevent hair growth. But before giving this treatment, we have to counsel the patient that none of the drug will remove your hair. So what will happen? It will prevent growth of new hair. And as you mentioned earlier, the hair cycle, that our old hair falls within 6 months to 1 year. So the old hair will fall and new hair will not grow. So we have to wait at least 6 months for pharmacological treatment to be effective. This is very, very important. You have to assure. Otherwise, patient will come to whether, sir, you have given so many treatment, so costly treatment, but it's not working, is not falling down. So you have to assure the patient যে না আপনার ভয়ের কিছু নেই, এটা সময় লাগবে, আপনাকে ধৈর্য ধরে অপেক্ষা করতে হবে, আমাদের কোনো ওষুধই আপনার চুলটাকে ফেলে দিবে না, বাট এটা নতুন চুল গজাতে বাধা দিবে। আর আমাদের পুরোনো চুলগুলো এমনিতেই 6 মাস থেকে 1 বছরের মধ্যে সব ঝরে যাবে, সুতরাং আপনাকে এই সময় পর্যন্ত ধৈর্য ধরতে হবে। আর যদি ধৈর্য ধরতে না চান সেক্ষেত্রে আমাদের হেয়ার রিমুভাল টেকনিকে যেতে হবে। কিভাবে হেয়ার রিমুভাল আমরা অনেকভাবে করতে পারি। উই ক্যান ইউজ ব্লিচিং, টুইচিং, epilation, just removing, shading, waxing, or we can use laser or electrolysis. Electrolysis is permanent, but these two methods are costly, but as well as it can cause scarring or burn to the skin if not applied correctly. Again, this is not a permanent procedure. After laser hair may reappear. Electrolysis is usually permanent. So these are the methods we can remove hair. So that's all about hirsutism. Thank you. We don't want a distressing hair growth, but we expect a joyful life. Thank you all. And if you have a question, you can put it into comment box. I will give answer later on. And again, for postgraduate student or other residents who are interested, can knock me. I will arrange a separate lecture for them, including the management details. Okay, thank you all.